Okay, so we're going to start by looking at electrolytes. So we've gone through fluid, you've had ABGs, and this one will go over the ins and outs of electrolytes. So terms and, with this, you're going to be looking at the terms and the values and understanding what the normal values are. One thing I will tell you is that some labs give different values than other labs. So always go by your assigned readings in these. You'll never see something, on a test like, the serum level is, if the parameters are 3.5 to 5, it's not going to be like 5.1. It'd be like 7 or 5.8 or something like that for like a potassium. So just know that the relative range and the close range, some of them, especially calcium, you'll see very different levels from many different spots. So with hyperkalemia, again, this is going to be with your serum level greater than 5 milliequivalents per liter. And then hypokalemia is your serum level below 3.5. Same with sodium. Hyper is your serum level for sodium, or hypernatremia as it's called. Your serum level of your sodium is greater than 145. And with hyponatremia, your serum level will be below 135. So it's important that you get to know these terms. So potassium being kalemia and sodium being natremia, because it's oftentimes that people get these confused. So make sure you get to know these terms and understand what they are. So calcium is an easy one. Hypercalcemia, again, serum level greater than 10.2 is hyper. Hypo is serum level less than 8.5. Again, as I mentioned, you'll see that the calcium is one that's different in many different resources. So go by the 8.5 to 10.2. With magnesium, the hypermagnesemia is a serum level greater than 3.0, and hypo is a serum level less than 1.8. So phosphate is the last one, and with phosphate, your normal range is 2.5 to 5. So hyperphosphatemia, the serum level is greater than 5, and hypo, the serum level is less than 2.5. So big thing is understanding where these are located. So this gives you the depiction of where the molecules are versus, or the electrolytes are in quantities. So whether they're in large amounts in the extracellular, small amounts in extracellular, large amounts in intracellular, or small amounts in intracellular. You can look at this and it gives you an idea of which of these are found in which area and in how much. Would you expect to see a lot or a little? So for potassium imbalances, when we look at our potassium imbalances, the big thing with potassium is that it really has to do with our cardiac system and nerve transmission. So when we have alterations in potassium, we're always worried about cardiac and neurologic issues happening. With hyperkalemia, the big causes of this are renal failure, patients using too much of potassium supplements. We see this in our burn patients, crush injuries, and patients with bad infections. You can also see this in patients who are taking potassium-sparing diuretics. We put them on these to try to pull that potassium back in at the end, and oftentimes will then lead to the hyperkalemia. We can also see this in patients who are getting ACE inhibitors. So the pathophysiology of hyperkalemia, basically there's an elevation in extracellular fluid potassium concentration. So the extracellular fluid ends up with an elevation or an increase in potassium, which leads to the hyperkalemia. Clinical manifestations that you're going to see with hyperkalemia. You're going to, like we said, it can cause alterations in nerve transmission and in your cardiac system. So EKG changes are one of the big things, specifically with your T wave or your QRS complex. The T wave can be elevated, your QRS complex can be widened. Patients can go into dysrhythmias. They can potentially even go into cardiac arrest. But we never give potassium IV push. Why? Because it's the lethal injection. Why? It stops your heart. It would put the patient into cardiac arrest. When we said there's issues with the nerve transmission, that can lead to twitching of the muscles. It can cause weakness, even numbness. Oftentimes you'll hear them say that's numbness around the mouth or of their hands and feet. And it can also cause GI disturbances such as nausea and diarrhea. So you want to look at that. So again, a lot of these things during mild times, sometimes you'll just see restlessness. Sometimes you'll see the patient has some intestinal cramping along with that diarrhea. When it's really severe is when you're going to see the major cardiac issues occur and even paralysis with the muscles. With hypokalemia, the pathophysiology, again, is a potassium deficit. So basically, the potassium level is going to fall below 3.5. Basically, the cellular and, the cellular levels of potassium can change. And if they drop too low in the extracellular fluid, the patient ends up with hypokalemia. So clinical manifestations that you're going to see in a patient with hypokalemia, so low potassium, are going to be often GI issues such as anorexia, nausea, and vomiting, weak peripheral pulses. The patient will often have issues with muscles such as weakness. They can also have decrease in tendon reflexes. They'll have ventricular dysrhythmias with this as well, and they could also have shallow respirations. Causes of this: vomiting, gastric suctioning, prolonged diarrhea, the use of diuretics and steroids, and inadequate intake are all things that can lead to hypokalemia. Other things are reduced intake of potassium can lead to this, increased entry of potassium in the cells, and increased losses of body's potassium. The people who are at most risk for dietary issues are patients who are elderly with low protein and inadequate fruit and vegetable intake. You also see this in people with alcoholism or anorexia. So it's one of the things that you want to be making sure that you're assessing for in those types of patients. So with hypernatremia, you're going to have an increase in your serum sodium level. This increased level is going to lead to a hypertonic type situation in the body. So again, the different types of hypernatremia are isovolemic, hypovolemic, or hypervolemic. And basically looking at those, you'll understand what's causing that particular type of hypernatremia. Causes of hypernatremia, causes that you'll see with hypernatremia include hypertonic tube feedings without water supplement, so giving someone a tube feeding and not adding the water to that, hyperventilation, diabetes insipidus, ingestion of over-the-counter medications such as citric acid, aspirin, or sodium bicarb can actually lead to hypernatremia. Inhaling large amounts of salt water, so people who have near drowning in a saltwater area, and inadequate water ingestion, so someone who's dehydrated or not taking enough fluids. Signs and symptoms include an elevated temperature, weakness, disorientation, changes in mental status such as irritability, restlessness. They're going to be thirsty, often with dry mucous membranes, and sometimes even a swollen tongue. They can have postural hypotension, they can have hypertension, or they can have sometimes tachycardia. Elderly patients, you often see an altered mental status occur. You'll see that they just have a change in mentation. Other clinical manifestations that you can see with hypernatremia include bounding pulses, weight gain, and as I mentioned, hypertension or increased blood pressure. With hyponatremia, basically what's happening is the extracellular fluid is depleted of sodium, and in this case you're going to have a hypotonic alteration of the body system. So the body's fluid is now a hypotonic. So it's not isotonic, it becomes hypotonic. There are several different things that can cause it, and hyponatremia can be categorized as isovolemic, hypervolemic, hypovolemic, and dilutional. as well as hypochloremia. You want to make sure you're looking at as well. With the types, basically you're looking at what's causing it. So the sodium loss can be caused by things such as those that we mentioned earlier, vomiting diuretics, excessive administration of dextrose or water, people drinking excessive water, so excessive water intake, burns and wound drainage, and then SIADH can be one. Also, elderly patients are at increased risk for hyponatremia because their kidney function can decrease and cause an inability or a decrease in excretion of free water. So that's another thing that can happen and be delusional. So excessive sweating is something that can happen that will stimulate thirst and get the patient to be drinking and drinking and drinking, which leads to the delusional as well. Sometimes people with mental health disorders, you'll see that they have that increased thirst, so they drink and drink and drink and drink, and they can also end up with hyponatremia. Other things that can lead to or that can cause this are congestive heart failure, cirrhosis, and issues with the kidney, such as nephrotic syndrome. So these are all different things that you can see that lead to this. Again, signs and symptoms are going to be nausea, muscle cramps, confusion, twitching of the muscles. The patient can end up with seizures. Delirium is often seen in our older adult patients, and even headache. Headache is one of the early signs that you tend to see this with the patients. The hematocrit is also going to be decreased if you have dilutional hyponatremia. So that's something you want to look at. But again, focusing on the neurologic issues such as the lethargy, confusion, altered mental status. Sometimes they just have an apprehension where they feel like something's wrong. So make sure you're looking at all these. And then the musculoskeletal stuff, such as the decrease or depressed reflexes, the weakness, and muscle twitching. Nausea and vomiting are common when it's less severe. So that's another thing that you could see. So make sure you're looking at all of these and assessing these. So with hypercalcemia, what happens with this is there's an excess of calcium serum concentration. Things that can cause this: hyperparathyroidism, bone metastasis with calcium reabsorption, prostate, renal, and cervical cancer. You see this in sarcoidosis, excessive vitamin D intake, and then some tumors that will end up producing PTH. Other things that can cause hypercalcemia, some malignant, so we said some of the malignant cancers, prolonged immobilization, excessive intake of calcium, immobility, and also an excessive intake of antacids because they have calcium in them. I'm just looking at the hypocalcemia and it's missing an A. I apologize. So those are the things with hypercalcemia. So again, signs and symptoms, a lot of times they have a lack of coordination. Dysrhythmias and heart block, even cardiac arrest can happen. So there's some cardiac issues that can happen. They have altered mental status or personality changes. Sometimes they're confusion or they get confused. They can also have a decreased level of consciousness. And then GI, anorexia, nausea, and vomiting can occur. Other clinical manifestations of hypercalcemia, you can see the patient develop constipation. They're also at increased risk for kidney stones, which I hadn't mentioned, and then bone pain and osteoporosis. With hypocalcemia, the patient has a low serum calcium concentration. A lot of times it's inadequate absorption, the ionized calcium being deposited in the bones or soft tissue, blood administration, or decrease in PTH and vitamin D, or nutritional deficiencies. They have inadequate intake of calcium, dairy products, and green leafy vegetables. Other things that can lead to hypocalcemia include pancreatitis, hypoparathyroidism, use of steroids or loop diuretics, renal failure, inadequate intake, as I had mentioned, and post-thyroid surgery, the patients are at increased risk for hypocalcemia. Signs and symptoms, the patient often will become very, the nervous system gets really excited, so they can have, increased excitability of the nerves. The things that you look for is tetany. So we have Trousseau sign, which is where you'll inflate the blood pressure cuff in the upper arm to 20 millimeters above systolic pressure, and you'll see carpal spasms in the hands within 2 to 5 minutes. That would indicate tetany. And Chvostek sign, which is where you tap the facial nerve 2 centimeters anterior to the earlobe, just below the zygomatic arch. Twitching of the facial muscle also will indicate tetany. So those are 2 tests to look at for hypocalcemia. They'll also have hyperactive reflexes, confusion, paresthesias, irritability, and possibly lead to seizures. So some of the neurovascular issues we had talked about with the increased excitability, they can have tingling, they can have muscle spasms. A lot of time, like we said with calcium, you'll see they'll talk about issues with their hands, their feet, and around their mouth. Severe cases is where you'll see things like convulsions or tetany. So it's increased neurovascular excitability. So hypermagnesemia is going to result from sometimes renal, so it's going to be a decrease in serum an increase in serum concentration of magnesium. It's usually caused by renal insufficiency or renal failure, excessive intake of magnesium, including, you can see antacids with that, people taking antacids, or people with adrenal insufficiencies. Those are the big things. So antacid intake, renal failure. Signs and symptoms of this, you're going to often see depression of the central nervous system and depression of the cardiac transmission. So these patients can end up in cardiac arrest. There's a particular issue with that, so you want to be really closely watching their cardiac function. So they're going to be something you need on a monitor. They can get facial flushing, muscle weakness, absent deep tendon reflexes, paralysis, and shallow or slow respirations. So again, it can cause a lot of issue with the muscular system, neurovascular system. So loss of the deep tendon reflexes, nausea, vomiting, muscle weakness, hypotension, and bradycardia, as well as respiratory distress. So everything is slowing. Hypomagnesemia is a serum concentration that drops of the magnesium, so it's a low magnesium concentration. We see this in people who have malnutrition, malabsorptive disorders, alcoholism, urinary loss, so people who have different types of renal issues, and patients who take loop diuretics are also at risk for this. Other patients that you can see this in is patients who have prolonged GI suctioning, diarrhea, intestinal fistulas, poorly controlled diabetes is another type of patient we see this in. Signs and symptoms include, again, increased neuromuscular irritability, tremors, tetany, hyperactive reflexes. Remember, a lot of these are pretty much backwards. Seizures and dysrhythmias is also an issue with this. So remember, magnesium is a big issue with the cardiac system. When you see hypomagnesemia, you can sometimes see a dysrhythmia called torsades de pointe. It's something that is a ventricular dysrhythmia that is oftentimes associated with MAG. The patient can also become very disoriented and very confused as well. So behavioral issues, huge. The reflexes, again, are increased. Muscle cramping can happen. Nystagmus of the eyes, again, we're worried about a lot of the neurovascular irritability, and tachycardia with hypotension. With phosphate, again, the serum hyperphosphatemia, the serum concentration is elevated. We see this with patients who have acute or chronic renal failure with a low glomerular filtration rate. We can also see this a lot with metastatic tumors. which will release the large amounts of phosphate into the serum. Long-term use of laxatives or enemas that contain phosphates can also happen in hypoparathyroidism. Usually with this, you're going to see symptoms that are similar to low calcium levels, which are caused by the high phosphate levels. So the signs and symptoms are going to be similar to hypocalcemia. With hypophosphatemia, the concentration is low, so the serum concentration drops. It's most common, you'll see it with malabsorptive disorders related to vitamin D deficiencies, use of magnesium and aluminum containing antacids, which is most of your antacids, long-term alcohol abuse, malabsorption disorders, respiratory alkalosis, the increase in excretion of phosphate by the kidneys that you see with hyperparathyroidism. So those are all the things you'll see with that. Again, with this, you're going to often see nerve and muscle function issues. With severe cases, you can see irritability, confusion, potentially even coma, seizures. Respiratory failure can happen because of muscle weakness, cardiomyopathies, and then bone reabsorption that leads to rickets or osteomalacia. So prioritizing patients with these types of situations is very important and a common thing to look at. So you would look at what patient has more risk factors or the most severe signs and symptoms related to the electrolytes. What you look at with that is, your patient who's at high risk for cardiac issues. So your patients with magnesium and potassium alterations, do they have signs and symptoms? Do they have chest pain? So really looking at, who has symptoms and who would you need to really make sure you're looking at first. So if you have someone who's got minor signs and symptoms, they wouldn't be your priority over someone who might be in a dysrhythmia with a high potassium level. So those are the kind of things that you want to look at. And then your actual nursing diagnosis is something that's immediately impacting your well-being of the patient. You'll get to know your nursing diagnosis. If it's a patient who's at risk for developing something, they're not oftentimes as serious. They're usually not going to be who you'd see first. You're going to see the person who has an actual diagnosis. So you have a patient who has impaired cardiovascular functioning. That patient is more serious than a patient that's at risk for GI disturbances. So again, you'll get to know that. You'll see so much prioritization by the end of the program. You're going to be so sick of it. I'm sorry. But make sure you start thinking about that as you're going through patients and doing practice questions.